Hey everyone, and welcome to RUBIN'S Mind Lab, where we break down the latest research into what it really means. Ever wonder why you can't stop procrastinating or why some people seem to stick with meditation while others drop out? Well, this new study dives deep into those questions, looking at a therapy called Mindfulness-integrated cognitive behavior therapy, or MiCBT. This research asked three big questions. First, who is most likely to even start this MiCBT therapy after their first assessment? Second, for the people who actually do the therapy, what makes them get better? And third, what makes people stick with the therapy and not drop out? It's like trying to understand the whole journey of someone seeking help. So, what is MiCBT? Think of it as a blend of two powerful approaches. You have cognitive behavior therapy, which is all about changing negative thought patterns and behaviors. And then you have mindfulness, which is about paying attention to the present moment without judgment. MiCBT puts these together in a 10-week program designed to help with all sorts of mental health issues. Mindfulness itself is about being aware of what is happening right now, inside you and around you, without getting caught up in judging it. Imagine noticing a difficult thought without immediately believing it or arguing with it. The researchers here are really interested in equanimity, which is like a calm, even-mindedness towards all experiences, good or bad. Now, a big problem with many therapy programs, including mindfulness ones, is that people often drop out. This is called attrition, and it is a huge hurdle. We want to know why people stop, because if they stop too early, they might not get all the benefits. So, how did they tackle this big question? They looked at a large group of people, over 300, who came to 2 psychology clinics and were offered MiCBT. They collected a lot of information about them before they even started therapy. This included things like their age, whether they'd meditated before, their diagnoses, and their levels of depression and anxiety. Life satisfaction and this thing called equanimity. They use some pretty advanced math and computer science tools like machine learning and survival analysis to figure out who would enroll, who would drop out, and who would improve. Let's talk about the first question, who actually starts the therapy. Out of all the people who were assessed, about 60% decided to go ahead with MiCBT. And they found some interesting things here. If someone had meditated before, they were way more likely to sign up for MiCBT. This makes sense, right? They already have some familiarity and maybe some positive experiences. But if someone had an ADHD diagnosis, they were less likely to enroll. This is important because ADHD can make it harder to follow through with commitments, and MiCBT is quite structured. Now, for the people who did start MiCBT, the big question is who gets better and how? They looked at changes in depression, anxiety, stress, life satisfaction, and equanimity. The good news is MiCBT seems to work really well for those who stick with it. They saw large improvements in stress and equanimity, meaning people became much calmer and more even-minded. Interestingly, having more severe depression or PTSD actually predicted faster reduction in distress. This might sound counterintuitive, but it suggests that people with these more challenging conditions might really benefit from the structured approach of MiCBT. Also, people with PTSD and ADHD saw bigger gains in their overall life satisfaction, which is fantastic. They also found that getting better at being equanimous, meaning more even-minded, was strongly linked to reducing distress and increasing life satisfaction. This supports the idea that equanimity is a key ingredient for getting better in MiCBT. Finally, let's talk about sticking with it. This is where things get really nuanced. They looked at the people who started MiCBT and who decided to stay or leave. They found that younger people, those who were less satisfied with their lives at the start, and people with a personality disorder diagnosis were more likely to leave the therapy early. And here is a really crucial finding. Prior meditation experience predicted starting the therapy, but it did not predict staying with it once they had started. This is super important. It means people who know meditation are more likely to try MiCBT, but once they're in it, their likelihood of staying isn't automatically higher than someone who is new to meditation. Similarly, ADHD predicted not starting, but it didn't predict dropping out after starting. This tells us the challenge for people with ADHD might be the initial decision to commit, not necessarily sticking with it day to day once they've made that commitment. So what does all of this mean? The biggest takeaway is that the reasons people start therapy, the reasons they stay in therapy, and the reasons they get better are not the same. They are driven by different factors. This is a big deal, and it's something we haven't always paid enough attention to in research. For example, the fact that past meditation experience helps people enroll, but not necessarily stay longer, suggests that maybe these folks are just more comfortable taking the leap into something familiar. But the actual commitment of MiCBT might still be a challenge for some. They also noticed that many people seem to drop out around the halfway point or shortly after. A lot of this might be because they'd already achieved their therapy goals and didn't feel the need to continue to the relapse prevention stage. This is what they call the attrition is improvement hypothesis, meaning stopping therapy doesn't always mean failure. It could mean success. Plus, In places like Australia, where this study was done, therapy sessions are often limited, so financial or practical reasons can also lead to people stopping. Now, what are the limitations? The researchers couldn't directly ask people why they dropped out. So, while symptom reduction is a likely reason for some, financial issues or life circumstances could also be big factors. They also didn't specifically look at how different stages of MiCBT related to dropping out or how chronic pain might affect things, which is a common issue for many people with mental health conditions. Overall, this study is super valuable. It shows that MiCBT is effective for a lot of different problems, and it gives us a much clearer picture of who is likely to start, who is likely to stay, and who is likely to get better. This information can help therapists and clinics to better support their clients and even make decisions about who might need a bit more encouragement to enroll or stay in treatment. It highlights that understanding the whole client journey from the decision to seek help to the ongoing commitment is key to effective therapy. So, what's my take on this? I think it's fantastic that they use such a mix of methods, from traditional statistics to cutting-edge machine learning. This really gives us a robust understanding. The distinction between predicting enrollment and predicting retention is especially insightful. It reminds us that people's decisions are complex and often made at different stages for different reasons. For future research, I'd love to see studies that directly ask participants about their reasons for dropping out, and perhaps explore if tailoring the dose or intensity of MiCBT based on those initial predictors could further improve outcomes and retention. What do you guys think? Does any of this resonate with your own experiences with therapy or mindfulness? Let me know in the comments below. If you found this breakdown helpful, please give this video a thumbs up. Subscribe to Rubin's Mind Lab for more science explained simply, and hit that notification bell so you don't miss our next dive into the fascinating world of psychology. Thanks for watching, and I'll see you in the next one.